RMO, and finally appointed Director of Preventive Services in the early 70s, when he served for 5 years. Then he left the Ministry of Health at the end of 1999 after being seconded to the International Trachoma Initiative, where he served for 7 years. In 2010, Dr. Kilima was appointed Chief Party of the Wajibika project, which closed at the end of 2013. He has long connections with IMA and World Health. When they came to Tanzania, Dr. Kilima was Director of Preventive Services and hence was directly involved in the welcoming of IMA World Health Tanzania. As we celebrate 20 years, he stands as the Chief Moderator for a very important panel discussion. Please put your hands together for Dr. Kilima.
Thank you very much, Moderator Taj. Ladies and gentlemen, I will moderate this session, and as you see, I'm moderating the session immediately after the crowning of the king or the world. Therefore, it's going to be safe for us. May I invite the panelists before I explain a few things about the panel. Edward Kirumbi. Edward Kirumbi is from the Ministry of Health. Dr. Kirumbi, please, start from the first chair. And Dr. Msemo. Dr. Msemo is from the Ocean Road Cancer Institute. Please start from right from the first chair, because you are being arranged there. These will be the panelists who will speak more on human resource. What IMA has impacted in the area of human resource. And the second topic will be the service delivery, and this will be carried on by the RMO from Mara, Dr. Winani, please, my long-time colleague. Together with Dr. Winani, we shall have Godwin. I don't know if Godwin is that. Godwin Ndamgoba, please. The third area, which we shall be looking at, as you have heard from different speakers, IMA World Health has expanded to other countries. 20 years ago, as Taj has said, seated in my office, I received somebody in the name of Paul Destine, and that was the beginning of IMA World Health coming to Tanzania, and not the beginning of, not the birth of IMA World Health. IMA was then 35 years. So we received IMA when IMA was an adult. And that's why we were trying to show them the environment, and they decided to go out of the box. Which box? You will understand that at the beginning they were just doing procurement, medical distribution, and medical supplies. And they got out of this box. And the impact got very enormous, and it will be explained by the panelists on this table. Therefore, apart from Tanzania, there were other countries which were doing something, and we shall hear some perspectives and some experiences from the Congo and also from Sudan. And this will be given by Larry. Welcome, Larry. And Bill Clemmer. Welcome. So our panel discussion will be guided by, first of all, we are very honored to have these panelists. There are people who know the organization. There are people who have worked with the IMA for some time. So we are going to get the real thing from the horse's mouth. And therefore, we are going to have a short discussion from each of them, not lasting more than 10 minutes. And then from there, I will invite a few, any clarification, not questions. If you didn't understand, I'll invite you for a clarification to ask if something was not very clear to you. And then at the very end, we shall have questions to all panelists. Therefore, if you have a question, please note it down because you're going to have some time to reply at the very end of the session. Now, we shall begin with Dr. Msemo. Dr. Msemo is an oncologist, currently Chief Executive Officer of the Ocean Road Cancer Hospital. Dr. Msemo will tell us more on the human resource, and he will be followed by Dr. Kirumbi. When Dr. Kirumbi comes in, I'll also introduce him properly. But for now, Dr. Msemo, please. You're welcome to speak to the participants.
Thank you very much.
I think.
Can I speak from here? Or you want me to?
Okay, that's good.
Yeah, you can speak from there.
Is it morning or afternoon? Good afternoon, ladies and gentlemen. Let me take this opportunity to thank IMA, World Health, as they are marking their 20 years of success story in Tanzania. I wish them many more years of success. I wish I would live and see them at 200 years, IMA at 200 years. But unfortunately, as a human being, I don't anticipate that to happen. I'm saying this because of the difference which IMA has made. And IMA has actually shown that a lot of these things with commitment and goodwill are possible. From human resource development to provision of medical services and cancer drug to patients and to set for cancer screening and so on and so forth. I personally started working with IMA 10 years ago. That was in 2005 when the first time I met Dr. Margaret Shengo. We were having difficulties in obtaining cytotoxic for our children with Burkitt's lymphoma. And one day he came into the when I was doing my all-round, by that time I was just come back from South Africa a year ago, and I was facing a lot of difficulties because then in South Africa everything was available. You just walk into the ward, you ask an answer, I need this and this is variable. When I went to my ward, the phone situation was totally different and a bit frustrating. And he or she comes and tells me, Dr. How are you? I say, okay, I'm fine, but I'm frustrated. Why? So I'm frustrated because I cannot perform it. I don't have blood for my patient. I said, okay. I said, here there is this organization called IMA. We are doing ABC. And I thought that was just a joke. But the next day, she came with consignment of anti-cancer drugs. And I felt very much pain, but probably my patient felt more relieved than I did, because much as those anti-cancer drugs, they were not very expensive for Burkitt's lymphoma, but 90% of our patients could not buy them from their own pocket. So it was a huge difference. So it was a life-saving. It's, it's something which, if you understand its cost and see the difference which it made, you realize that there are things which are not very expensive but they can save life. Now, it happened that we shared the same vision. I had a discussion with them, and I told them that, look, we have all these patients who are referred to Ocean Road, but they come late. Cancer like Burkitt's lymphoma is curable, but a lot of our children would come with disseminated diseases and it will become difficult. Go to second line chemotherapy, up to third line chemotherapy. and sometimes you are not able to cure them. Why is it that we cannot have a program whereby some of these children can be treated in areas near the area where they are coming from? There came an idea of having different centers in the country. The intention was to have all regional hospitals in our country being able to provide treatment for bacterial reform, because it's not a complicated thing, and it's doable. And the drugs which are needed are not complicated either, but it comes to the issue of human resource capacity. And cancer drug cannot just be given like the way initiated malaria. You need to train people how to know them, how to store them, how to administer them, how to monitor toxicity, and that kind of thing. And this is how our relationship with the IMA started. We started the organized workshop at Ocean Road. We started training people, calling people for workshop from different regions. And by that time, it just happened that they had started some in Israel. But even in Israel, the program was still at an infancy. They had just started, and they came to Ocean Road. Now, they felt that Ocean Road, it was an opportunity because it was a National Cancer Center. It was a big center, and it really worked. And we moved quite well. We trained a lot of people. Really not a lot, but I would say significant, because they were able, from those people, they were able to start the treatment program in different centers. But our ambition was to have almost each and every regional hospital have personnel who can handle these children, so that they don't have to travel thousands of kilometers to Ocean Road to get this. At the time when they come late with disseminated disease, and you lose their life for something which is done. So we were able to do that. And I don't recall how many personnel we trained, because there are quite many, but probably she has the data. But that's the work which we did with IMA, and it has a big impact. And we went further to launch a bacterial reform national treatment guideline. That was the first guideline, national guideline to be developed in the country. IMA played a very big role. We had a very good experts at Ocean Road, but we had no financial backing. So we would call meetings, and they would finance it, they would call a meeting, and then we would move forward, and finally we reached the consensus. And we launched the Bucket Reform Treatment Guideline. And I remember it was launched there at Kurasini by the then Chief Medical Officer, Dr. Mtasimu. So that was a very big success story. And from there, other national guidelines such as cervical cancer prevention program guideline, they followed, and now we are on other guidelines. But it started with the packaging format with IMA, and we showed them that this thing can be done nationally, and we are able to do that. But we did not end the relationship there. We started building the human resource capacity for cervical cancer prevention program. Screening. In 2001 at Ocean Road Cancer Institute, together with the International Agency for Research on Cancer, we started a training program on visual inspection with acetic acid. The simplest method of cervical cancer screening. That by that time, the cost for it was $50, whereas you needed about $20 to do pap smear, and it was found that the result were almost the same. So again, IMA came up saying, yes, this is a nice thing, we need it. We need to build capacity because we need to scale up. Again, we trained their staff, and from there they went also, they trained many more. Up to now, we have more than 13 regional hospitals in this country whereby cervical cancer screening program are being done, visual inspection with acetic acid and glucose iodine. And the thing started with Ocean Road and IMA. So we did a very good job of that, and that has led into the development of a cervical cancer prevention control program in the country. So that's another area where we managed to build human resource capacity together with the IMA for the benefit of our people. And then there came something which was at the bottom of my heart, which has not been mentioned. That is palliative care. We have been working with the IMA on that front, and we trained the IMA staff, particularly Sister Shengo and Veronica. They went further to do BSc in palliative medicine at Moderator University. They happened to be their supervisor. They're quite enthusiastic and hardworking. So we work together. Now we have developed the National Palliative Care Guideline, and that was supposed Palliative Care Policy Guideline. It was supposed to be inaugurated during RMODMO's meeting, which happened at the end of. I think I can just end up there in brief, but there is a lot of things which IMA has accomplished, and that's why I say I wish I could see their 200 years. I think that it will be just amazing. Thank you very much.
Thank you very much, Dr. Msemo. I think what you told you're welcome, Dr. Kilima.
Thank you, Moderator, Dr. Kilima. Good afternoon, ladies and gentlemen. Yeah, Dr. Kilima is speaking the truth because I firstly knew about IMA about 23 years back ago. That was in 1992 when IMA was supporting the onchocerciasis control program, which was being implemented in collaboration with Ministry of Health, specifically in Ulanga district, that is Mahenge area, and also Kilombero district by that time. IMA provided vehicles, IMA provided funding, and provided also the medicines, that is ivermectin or mectizan, which were being distributed to the people in those two districts under mobile outreach approach. And in year 1996, that's close to 20 years back ago, that was the time when IMA was housed under the Christian Social Services Commission, that is Mr. Peter Maduki, the director of that NGO now in Upanga area there. So IMA officers were housed in that building and they are working there. And at that time, I was among a small team of Ministry of Health people who collaborated with Dr. Glenn Brubaker, who was a technical personnel from IMA, housed in under CSSC, and we worked together in the development of the National Onchocerciasis Operation Plan 5 years. And by that time, Dr. Peter Kilima, our moderator here, was my director for preventive services in the Ministry of Health. We also thanks a lot Paul Destine, who was the director of IMA in Windsor, the United States of America. By that time, he paid visits several times in this country to help us in initiation of the National Onchocerciasis Control Program. But IMA World Health collaboration with the Ministry of Health, specifically the National Neglected Tropical Disease Control Program, was further enhanced during the launching of the National Neglected Tropical Disease Control Program, or in short form we call it the NTD program. That was in year 2009. And between year 2009 and 2010, we close collaborated with IMA World Health on health system strengthening through the capacity building. Through this collaboration, national teams were trained on NTD. Then the regional NTD secretariat were trained, and district NTD secretariats were trained on NTD. And also this went down up to the health facility personnel training and up to community drug distributors, whom we call them CDDs. Now, taking a snapshot between year 2011 to 2014, over 40,000 community drug distributors in the country were trained under collaboration between IMA World Health and the Ministry of Health NTD program. And over 80 million treatments were received. This is through treatment of onchocerciasis, through treatment of schistosomiasis, trachoma, and lymphatic filariasis and soil-transmitted helminthiasis. These are the 5 diseases which were integrated as a NTD program since 2009. And through this collaboration, about 700 regional and district TOTs were trained, and over 700 M&E personnel were trained at the regional level as well as district level. A lot of mentorship to personnel at lower levels have been done through our collaboration with IMA World Health, and a lot of supervision and monitoring for program activities at all levels we are conducting together. We usually conduct review meetings, planning, and budgeting with the regional and district teams at the beginning of each year, and also financial management training. Another very important support which we receive from IMA is secondment of IMA World Health personnel. IMA World Health has seconded an M&E personnel who spends almost 100% of his time in our NTD program and NTD office. Dr. Andrea Shala, are you here? If you are here, please stand up and raise your hand. That's Dr. Andrea Shala, M&E personnel, and he's the engine of NTD. Please clap hands to him. Another person also is pharmacist, who is dealing with the procurement, distribution of medicines, Franco Makoma, but today he's attending another meeting in Morogoro, and also admin and finance officer, Bernard Kilembe. Please stand up and clap your hands. Oh, yeah. Now, we are facing some challenges, programmatic, not in our collaboration with IMA, but programmatic when we are managing the program in the field. Now, some of the challenges include the inadequate government contribution of funds. Also, these community distributors, most of them, we are facing a lot of high attrition rate of these community distributors because they are volunteers. They are not be paying any salaries, see? And these are the ones who are distributing the medicines to the people in the community. And also some low treatment coverage in some districts. Now, how do we do with this? When we sit down together with IMA World Health, we usually organize sensitization and mobilizations of personnel and leadership at all levels, from district level downwards, and this really helps a lot in achieving our objectives and goals. Now, what are the lessons which we learned from this experience of collaboration with IMA? First of all, we learned that government cannot do it alone. Partnership is the key for strengthening of health systems in all countries. But we also learned that our partnership with IMA has demonstrated empowerment of government with results of government ownership of the programs where the government takes the driving seat. Let me explain a little bit of this. In my about 26 years working with the Minister of Health, this is a peculiar thing which I have found working in cooperation with NGO IMA, different from other NGO, because IMA will not go to the district or the region to do a supervision alone. We sit down together, we plan together, we budget together, and then we move together to do supervision, to do training and everything. As Peter Maduki said in the morning, actually we do collective decisions and very good transparency. So, ladies and gentlemen, the capacity building under collaboration with IMA World Health has resulted in all these achievements. Thank you very much.
Thank you very much, Dr. Kirundi, and I appreciate that you mentioned some figures on the people trained, and we note that it's thousands and thousands of people trained. So I think from the numbers you gave, the impact is obvious. Any issue of clarification, only clarification, no questions to him because he will still be around. He was clear. So we are moving now from the area of human resource and we are going towards the area of service delivery. And in this area we have two panelists. And we have Dr. Winani. Dr. Winani is a veteran in the area of medicine, actually, in working with the Ministry of Health. He worked for a very short time as under someone, but from there, he assumed the role of leadership in the area of health. As a DMO, as RMO, he has been RMO in 5 regions, and so we are exposed to that immense experience and linking that one with the collaboration with the IMA. Dr. Winani, please, you're welcome. And just to help you, when you see me standing, it means time is remaining only 2 minutes. Otherwise, I'll be seated.
Let me assure you that I'll finish before time. Good afternoon. Yeah, the responsibility of ensuring that the citizens of this country get quality of health service is actually the responsibility of the government of Tanzania. But as you know, this is a huge task. The government alone cannot do it. So it invites faith-based organizations, partners, development partners like IMA, and of course private people. Now many times there are success stories. One of that success story is the collaboration with IMA. It has been a success story in this partnership. We have been working with IMA for more than 9 years in Mara region. We have been working with them in the care and treatment of HIV, cervical cancer screening, and Burkitt's lymphoma, as you have heard. But specifically, we have worked with IMA in the following areas. Human resource, as you have said, human resource is a crisis in this country, and IMA has been supporting the region by recruiting staff and providing salaries with the idea that in the future they become absorbed in the government system. So this has been a very important area of collaboration. This staff include clinicians, nurses, and data clerks. And these staff have been trained in many areas, including care and treatment, prevention of mother-to-child transmission, early infant diagnosis, commodity management, and financial management. This has improved the capacity of these people, not only in programs that are supported by IMA, but in the health system in Mara in general. Another area is on the infrastructure development. There are two areas: renovation of clinics, laboratory, pharmacy, dispensing rooms, RCH, and labor room, plus construction of new infrastructure like CTC clinics, laboratories, and pharmacies. Now, doing this provided a very conducive environment for provision of health services in Mara region, plus, of course, improving the quality of health services. The other area was in planning, leadership, coordination, and joint supervision. Through IMA, we have worked together in all these areas, and we have now established a forum where we meet biannually. All stakeholders in the Mara region come together under the chairmanship of the regional commissioner and review the performance of all the programs in Mara region. This has improved so much the coordination of the partners in the Mara region, plus, of course, the performance of the interventions that we are doing in our region. Another area is about the communication and transport. They have provided vehicles for the RHMT and CHMTs for supervision and transport, and of course, some equipments for, and also computers and the other equipment to strengthen the HMIS. Now, in conclusion, the partnership with IMA, of course with the other partners, has resulted in the following very significant things. Number one, new HIV infection in Mara region has decreased. Because, you know, in 2007, the prevalence was 7.7, and with the collaboration of IMA and other partners, it has decreased to 4.5. So this is very significant. Secondly, HIV/AIDS people who are eligible to get ARV are getting these drugs, and retention has improved so much. Now, as a result, these people are now living a normal life, as we heard this morning, and they are productive economically, helping their families and developing their nation. The other thing is that we have these 4 hospitals now in Mara regions which are doing cervical cancer screening, and this has improved the early diagnosis. People are being diagnosed early and treated, and increasing the survival rates of cervical cancer. More babies from HIV-positive mothers are born free of HIV, and the capacity of health workers has been strengthened and is much more strong, and the health system in Mara region now is stronger than before IMA came to Mara region. So we thank you very much, IMA, for coming to Mara region, and we are assuring IMA that we are going to support, and we are committed to working with you. Thank you very much. I hope I kept my promise.
Thank you very much, Dr. Minani, because you made me stand. Yeah, and I think what Winani has pointed out is again very important, particularly the reviews and the training which he pointed out, because it's very important that people review what they do. Without reviews, you never know where you have come from and how you shape the future. So thank you very much, Dr. Winani, again. And any clarification for Dr. Winani? Clear again. So we're going to have the second presenter on aerial service provision, and this will be by Dr. Ndamgoba. He is working with the Commission for Social Services, the Christian Social Services Commission, and he was actually a policy advisor and is trained in hospital management. Dr. Ndamgoba was the first officer who represented CSCSC in the training process. So he has got hands-on experience, and let us sit in a manner that will allow us to hear him. Dr. Ndamgoba, please.
Yeah, thank you very much, Moderator. And I'm very briefly going to say something about our collaboration between CSCC and the IMA, and actually AIDS relief in general, because IMA, in the implementation of IRT project, IMA forms one of the consortium members. Our program, which we are running, ART, the transition process started in the year 2009. And this was initiated again by AIDS Relief, which is, as I said, is a consortium, one of the consortium members of which includes CRS, IMA, WWF itself, Futures Group, and IHP. Actually, we didn't have any idea on how the project will operate when at first we were contacted by AIDS Relief, from which angle and how the services will be conducted. To us, it was something strange. But we had some a bit of experience in running Global Fund project, HIV project. And to us, when we were contacted by AIDS Relief, we say, oh, this we can put into one basket of the Global Fund, because we are already operating the Global Fund, and we are actually dealing with HIV, so we can put them together. And but it seems as if AIDS Relief didn't understand us on how we are going to deal with this project. So we started with the discussion between CSSC and the AIDS Relief Consortium Management Team. And this we did in rotation. Sometimes they were coming to CSSC offices, and we moved those to IMI offices, CRS. This was done in order at least to be clear on the activities to be transitioned. Because as I've said, for us we thought that this we can put it together with the Global Fund. So with these meetings, so it was meant that we can at least gain an understanding on how this project will be managed. We later learned that the AIDS Relief approach to transition with these meetings included transferring the overall program management responsibilities which AIDS Relief were carrying to CSSC. Then you say, oh, so you can't put them together in Global Fund. And so with these discussions, I remember in May 2009, we formed a sustainability working group. It was formed, that was between AIDS Relief, consortium members, and the CSCC. With this sustainability working group, this provided a strategic and a technical direction on how the transition process will go. And then we said, okay, but there are other technical issues which we need more people and more technical people about the program. So another task force was formed in order to assist the Sustainability Working Group, which was actually responsible in discussing more technical issues concerning the ART program. Thereafter, in between, actually that was in June, an assessment tool was developed. And CSSC took an active role during the sites assessment. I mean the sites where the services are provided. And actually with this, because we were very much involved, this gave a clear idea on the activities taking place to the local partner treatment facilities are running. The more we had these meetings, we continued to understand the project, and that was actually good through the meetings and be involved in the assessment process. Some of the tasks performed by IMA were health in collaboration with other AIDS relief team, as I've said, in the early stages of transition, was to develop the capacity of CSSC and the local partner treatment facilities, especially in the areas of project financial and science management, which was very much done by IMA World Health. And the other services like care and treatment was taken care by other consultant members. IHB was part of it. IMA also and the entire AIDS relief team provided accompaniment in taking over the transition sites, the local partner treatment facilities, which were formerly run by AIDS relief. In July 2009, the revised transition plan was approved by CDC, because these are people who are financing this project. And this was a 5-month transition work plan, which was supposed to run for a period between October 2009 to February 2010. IMA World Health in collaboration with AIDS Relief arranged for institutional assessment. When I say institutional, assessing the CSSC in terms of capacity to handle the project and also to assist in the smooth running of the project and other activities. The first assessment was done by CORAT, and this was done in July 2010, and they identified some areas which needs to be worked upon, and all this we tried our level best to make sure that we worked on them accordingly. That was the first assessment done by CORAT from Kenya. And another assessment, which was the second one, was done in December 2010. The arrangement of doing this kind of assessment was done by CDC. And again, we identified even more areas of weakness, which we were supposed to rectify before we take on the activities. And that is included again, the CSSC, in terms of running, organization, financial, programmatic areas, from the head office to our zone offices. We have our zone offices where actually most of the services are centralized there, and the program activities where they are carried into the local partner treatment facilities. And I don't know if I mentioned this, together with the AIDS Relief and the CSSC, we identified the sites to start with. These were 8, 4 from one district, Sengerema, and the other was from Roya district, where our bishop was coming from. Funds to run the activities for the first 8 sites were released by CDC. So that gave us a go-ahead to start the project. And that's where we're still running the project. Moderator, maybe let me mention some few key successes which so far we have reached. CSSC was the first. When I mean the first in Tanzania, we were the first in Tanzania to run a project like this one. So to us, we say, oh, formerly it was run by international organization, but now it is run by the local partner like us, CSSC. So for us, this we counted as one of the successes to us. And again, we still continue implementing the activities. We started with 8 sites, as I mentioned. Now we are running 325 sites in 14 districts, including where my neighbor is coming from, Mara. And these are in Mwanza, the entire Mwanza region, and Geita, and also one district which is Norolia. I can actually say that this is contributed by the fact that the transition process went on well, and we got adequate support from IMA World Health in terms of project and financial management, and the entire AIDS relief team. Also, one of the key successes, well, we started with a few staff, but now we have quite a number of staff who are running this project. We have our own experts. But I can also say, but using the knowledge gained from the transition process, this has led to the self-confidence of the services we are providing. Another key success is the financial part. We are accessing funds direct from CDC. And we are among the few partners, local partners, accessing funds direct from the American government to implement the project. Moderator, maybe let me say some challenges. There are not many, fortunately. But we have the challenge which we faced for the first time. And the other people, they are surprised why I mentioned this. Because CDC can only disburse funds through the PMS system. And for us, we were not used to access funds through this system. So for us, it gave us a lot of challenges because you have to, password and other kind of things. We say, oh my God, what is this now? And at first, we were delayed to get it. It took quite a number of days before we can access funds. So this actually was the first challenge we faced, and we can actually say that for us, it was a challenge which actually impacted our program for the first time. And we faced some anxiety again. Of course, you can see taking a big project like this as a rock partner for the first time. But fortunately, this has been solved now as we continue implementing the project. So these two challenges, I can actually mention them. The last point I'm going to talk about is the lessons learned through our collaboration with IMA and AIDS Relief. The good guidance and encouragement received from IMA World Health and the AIDS Relief team in general has led to a successful implementation of ART project, the one we are running now. And working together and on-job training provided by IMA and AIDS Relief in the now lead project in some technical areas has promoted a quick learning because we are, as I said, we were always working together in the early phase of starting our project. And what we can say is that success of the project implementation, again, depends on the regional and the district leadership. In some districts, our experience that we are getting some problems to work. But the other areas where I find the district and regional authorities are ready to cooperate, that's where we actually, it is easy even to implement the project. And I think that is also facing the other partners are facing. And the last one I want to say, Moderator, is on job and accompaniment of the team like IMA would enable any organization to perform better. Because without a good cooperation we got from IMA and its relief team, we couldn't have been able to implement the project. As I've said, we are from 8 to 300, and I think we continue to take more sites from other places. Thank you, Mr. Moderator.
Thank you very much, Doctor, for your presentation. And we're now shifting a bit to another area, the area of other perspectives, some international experiences. As you know, when you are doing something, you get to be lucky when you can compare with your neighbors. Maybe if you're working in a district, if you can compare with another district, that's an opportunity. And in here, we're going to hear from our colleagues who have worked in other countries, that's Sudan and the Congo. And such experiences are very useful because we can learn what other people are doing. So to start with, I invite Dr. Larry He has a diploma in public health and nutrition from the University of North Carolina, and he has worked in several places, but since 1987 he was working with the Presbyterian Church in USA as a health specialist in Africa. He is currently working as a country director of IMA for World Health in the DR Congo. So please, we are ready to hear some experiences from our neighbors in Congo. For your information, Kabila was raised here during childhood, so we are very close.
Thank you very much. I noticed you didn't try to pronounce my name, which is Stresho. It's even worse to spell. I've actually been working in Congo for the last 27 years, but IMA has been there for the last 14. And the way that came about is that I was working with local NGOs, trying to help develop their capacity, because I saw so much of the funding that was coming into the country was bypassing the actual people of that country and just going straight to NGOs that were implementing whatever the donors were asking for. And I felt like there was a lot of solutions locally that needed to be highlighted and financed so that the country could develop. So in 2000, when the local group I was working with got the capacity to attract a large grant from USAID, I looked for an organization that would respect the local partner and respect the ideas of the local people. And I found that in IMA. It's actually turned out much better than I expected. We're much larger than we anticipated, and we've had spin-off organizations that are now the largest local health programs in the country. But what made that happen is a different approach. And a lot of people have talked about this, the collaboration with the government, the collaboration with local partners, but the willingness to try what the local partners would like to see happen and supporting them in that so that they could show solutions to their own country. Another part of it for IMA is being very comprehensive. Now, I know here in Tanzania, you see mostly the vertical programs of IMA, but actually the largest programs that we have throughout the country or throughout the world are health system strengthening and very comprehensive. Since we're running short on time, I'm not going to cover all of it, but I'm going to highlight the last project, the one we're currently working on, and how this supports the ministry and the 6 pillars of health in Congo. And when we talk about supporting the 6 pillars of health, it's not just supporting the service delivery of those 6 pillars, but it's working with policy development, the systems development, behavior change that's necessary to make that all work. That's not often we talk about policy as being like the national level and behavior change at the community level. But that's not really the case. There's policies at the community level, there's behavior change at the national level, there's behavior change at the donor level. All of those things need to happen for health systems development. So to go quickly over that the cycle of doing mass distribution and then just depending on routine was causing huge dips in the utilization rates. And so there was a local church group that had come up with a strategy of hang up that was very effective. We incorporated it into our program, and now we have a 97% utilization rates within the areas of our program for bed nets. All 900 health centers within this project have family planning, have sexual violence programs, have nutrition programs. So a lot of programs that other organizations are ignoring or not prioritizing, we see the impact of that and incorporate that. The nutrition is specifically interesting because it required training and supporting 8,000 volunteers. So every identified child with malnutrition is followed up at the home and mentored and tutored through back to recovery, just using local resources. Another pillar is medicines and technology. Most projects in the country were bypassing the national system. So we emphasized building up the national system, opened up new drug depots, regional depots, and we have put $29 million of drugs through the national system in the last 18 months. We've looked for a sustainable solution to like the cold chain. Most programs are using vaccine refrigerators. We went to direct drive so we could avoid using batteries. These refrigerators will last for 20 years to make a sustainable cold chain system for the country. In financial systems, we look for a way for the community to lower the cost for the poor. So we set up local insurance programs connected with IGAs, income generating activities, so that even the poorest of the poor could afford the payment for the insurance. And we've been able to lower the cost of healthcare with that. We saw a lot of waste in the hospitals with poor management. So we're developing software for hospital management that links to the national system, helps convert the accounting systems over to the national system, and links in with the information systems. Huge challenge, but it seems to be going well. For human resource, only 30% of the workers in Congo that are doing the work are actually paid. But there's double that amount of people that are getting paid who don't do the work, the ghost workers. So we're working with the national government to validate all the workers. We've put the list on a cloud-based information system, and we're systematically going through the country trying to clean up the list, make sure that people that are doing the work are getting the salary and that they are qualified to be doing that work. Of course, another part of human resources is training. In our current program, we've trained about 14,000 people in the last 18 months, but over the last 14 years, we've trained over 50,000 people with IMA programs. Information systems, we're the lead agency for the government to install the district health information system. In some areas, in 6 months, we have a 98% utilization rate. But all of this depends on good leadership and governance. And again, that's at the national level, working with the government. It was already mentioned that every trip that we do, we go with the
Sudan. So such is the experience, and I think Dr. Clema will be very important for us to show us how he can raise that money. So, Dr. Clema, please.
Thank you, Dr. Klima. You know, it's very difficult to talk about health system strengthening in South Sudan without talking about the Democratic Republic of Congo. And you know, we really cannot speak about our roots in the DRC without speaking of Tanzania. So here's the story. I was a missionary doctor in Zaire, Congo for 6 years before IMA started their programs in the DRC in 2000. Well, you know, I knew how to do a spinal tap, but not how to write a proposal. I could do a C-section, but I couldn't run a program. I knew how to write a prescription, but I've never written a budget. So when I was asked to be the first country director of DRC, I was sent to Tanzania to learn from the group here. And I must say, my distinguished colleague, I learned that partnership is key to health system strengthening, and that the responsibility of health rests not with the NGOs, but with the government. It is the government who is the ultimate guarantor of health care in this nation. So with those lessons learned, I moved to the Congo. As Larry mentioned, we had a very successful 10 years. My budget my first year was $1.2 million. And after 10 years, we had cumulative funding of over $100 million. And it was time to go. Well, you would think that after 10 years serving IMA in the DRC, they sent me to a country like Tanzania. But I was asked to go to the new Sudan, South Sudan, where I will speak briefly about health system strengthening. Well, you know, to understand South Sudan, we really need to look at the roots. I mean, this is a country that had been in civil war for 35 years. A generation of school children, a generation had missed school. The new leaders of South Sudan were former military leaders, good people who had led, good men and women who had led their people out of the desert into a new country, who had great passion and determination to build the newest nation, but aside from fighting battles, had very little skills in terms of running a nation. Part of the peace dividend for the new Sudan was a $90 million grant monitored by the Multi-Donor Trust Fund to help build this nation. $90 million. You know, most countries would build roads or bridges or parliament buildings. This country, South Sudan, the president stood up and said, "We are Africa's newest nation. We shall be a world-class nation. And we shall do that by having world-class citizens." And with the $90 million, he invited organizations to come into South Sudan, not to build bridges, but to build systems. And within that context, in 2007, IMA was asked to come into South Sudan and to help build the first healthcare system in that country. Well, the challenge was not the government, not the heat, not the mosquitoes, not the war, but the NGOs who had been in South Sudan for years and years, who did not recognize that the ultimate responsibility of healthcare rested with the government, who maybe didn't have experience in partnership with the government. And so when we came in, the first challenge was to, you know, design a district and a regional medical system to carry us through. And again, our thanks to Tanzania. We borrowed from your policies, rules, regulations, and mechanisms of the district and regional medical offices in Tanzania, Asante Santa. We brought lessons learned from Tanzania and DRC to train district and regional medical supervisors. We bought them vehicles, we trained them, laptops. And at the end of 2 years, again, our biggest challenge was not the healthcare systems. We had regional medical offices, we had district medical offices, they had Jeeps, they had VSATs, they had laptops. They knew how to do things. But 50% of the healthcare facilities in South Sudan were managed not by the government, but by the NGOs. Oxford, CRS, IMA, all of us, who maybe did not share the same vision of partnership and authority. And though they paid lip service to the new regional and district medical authorities, they didn't let them supervise, They did report as they should. They reported back to their donors. So the lesson learned was again the Minister of Health, who stood up before the NGOs and the donors and said, we have two healthcare systems in South Sudan. We have a government system and we have an NGO system. And this is a world-class nation. We shall have equity and parity in our systems. And how he realigned us, the NGOs, was he went to their donors. I mean, the best way through NGOs are through their donors. So he met with the World Bank and with USAID and with DFID and reminded them that partnership was key, but the authority and ultimate responsibility of health was with the government. And he thus instructed the donors to have one donor per state or one donor per region. And then IMA became the essential fund manager. So all the funding in a particular region went to one donor. And so all the NGOs that were running health programs in that district or region worked for the same donor and the same fund manager. And this was a mechanism to realign priorities. And yes, we were able to restructure the 6 pillars of health. We created a national health information system. We supervised. We were able to realign all the healthcare salaries. One of our biggest challenges was harmonization of healthcare salaries in a two-tiered system. Who makes more money? The healthcare workers that work for the government or the healthcare workers that work for the NGOs? And clearly, the NGO healthcare workers were paid more. So through government intervention, through donor realignment, we were able to realign salaries and policies and reporting. The lessons we learned is with the right vision and the right determination, we can realign our priorities. We believe in partnership, but we also believe that the host government is the ultimate guarantor of health. And so IMA is very privileged for the lessons learned in Tanzania, for the experience in the DRC, and for the great ideals of the South Sudanese government and their ability for us to go in and work hand in hand with them. And we thank you for this occasion this morning to share these experiences.
Thank you very much. Dr. Clement is such a good speaker that I almost preferred to stand up so that he continues to speak. So thank you very much. And it is very interesting for us to learn that some of the ideas from Tanzania were actually useful for the process. Now, ladies and gentlemen, another applause for all the panelists, please. After which, shoot them with the questions. It's question time, and the modality is, when you have a question, when you stand up, please say who you are and ask your question. Short question, one question per individual. There will be a lag time of 3 minutes. If there are no questions, the session will be closed. Maybe while I'm waiting for the questions, I would just like to ask you, Dr. Kilumbi, you said that one of the challenges is the low allocation of resources from locally. What are the efforts being done to sort of alleviate this kind of challenge?
Thank you, Sir Moderator. The efforts which are going on here definitely is advocacy. In collaboration with IMA World Health, we are running this program, ATV program, in 9 regions of Tanzania, starting from down to the south there, Mtwara, Lindi, Pwani, the center, Dodoma, Singida, Manyara to the north, Tabora, and Rukwa down there to the north, 9 regions. So what we have been doing all these 3-4 years, we've been conducting advocacy to the regional level. And when we conduct that advocacy meeting, we make sure that the regional commissioner, RC, is the chairperson of that meeting. And usually the invitees are being invited by him or herself, the regional commissioner. So you find that everyone. So that is the main effort which we are doing. And actually, it's yielding some good results in some areas.
Thank you very much. Any other question? Right. Given the time, I think we shall now move to the next session. But before we do so, I would ask you to again applaud the presenters. Thank you very much. Thank you very much. You can now go back. We have definitely learned a lot from this panel discussion. It has been very useful, and I think some of the points raised have been learning points on our side. It has been a pleasure for me to moderate this session, and let me now move you over to the main moderator, Mr. Tagi, who is hiding at that corner. Tagi, please. Thank you very much.